parathyroid surgeon himself. So I, in fact, have questions for him at the end of this talk. The topic which I was given was failure of parathyroid localization. But for this audience, I think it's best that I speak about localization as well as failure to localize. So we begin with a fun fact. If you notice, most of endocrine societies would have the Indian rhino as their emblem. And it is there because parathyroids were first discovered in an Indian rhino in a zoo who died of a minor trivial injury and had a rib fracture which collapsed his lung. They have a single pleural cavity and died. And then they did a autopsy of him and they found there were large glands associated with the thyroid. And this is how the whole journey of parathyroids began. So that's a fun fact for you. So, a prologue, we know that PTH and undiagnosed hyperparathyroidism, primary hyperparathyroidism, is on the rise. The most usual cause is a single gland adenoma in 85%, multi-gland hyperplasia in about 14 to 15%, and rarely parathyroid carcinoma. Surgery is indicated as per the indications given by the fifth meeting proceedings. Calcium more than 1 gram deciliter above normal, younger individuals because they are more likely to progress, bone involvement and renal involvement. These are the criteria which I've mentioned. So then why is preoperative localization crucial? It's crucial because for a long while we thought, and this comes from a radiologist, this is in the 90s, and he would say, the best localizing study for hyperparathyroidism is to localize a good parathyroid surgeon. So we moved a long way from there. We now understand that a good preoperative localization is important. And it's important because the preferred mode for primary hyperparathyroidism surgery is now minimally invasive parathyroidectomy and not the conventional parathyroidectomy. And this has several advantages in terms of smaller incision, reduced operative time, faster recovery, improved cosmetic outcomes, and lesser chance of injury to surrounding structures, including the recurrent nerve. Preoperative localization is an integral part of minimally invasive surgery because the surgeons need a direct approach onto the pathologic parathyroid gland. And precise localization will minimize trauma and prevent injury to the surrounding vital structures. This is also very helpful when the gland is not in its usual position. In ectopic glands, which may be present in up to 15% in multi-gland disease, or when there is a redo surgery. So these all are the necessities why pre-op localization is necessary. Now coming quickly to the topic which I was given today, what is failed localization? So failed localization, there is no actual definition for it, but let's imagine this scenario. There's a situation where there's a lab evidence of hyperparathyroidism, all the indications that we gave in the previous slides, but imaging or other diagnostic techniques have failed to pinpoint the exact location of a abnormal parathyroid within the neck. And this is a situation where your minimally invasive or focused or a targeted surgical approach will not work, and you will probably have to go to a more extensive surgical approach. So there have to be ways to circumvent this so that we can localize the parathyroid and let our surgery not be extensive and not let it be in vain. So I'm going to enumerate a few pre-op localization studies. We are going to talk about intra-op localization after we quickly go through a brief of each of these studies. And the way I've in the chronology I have marked them is also the chronology in which they developed, and also more or less the order of importance in which you will use them. So USG neck is basic. You can occasionally do an USG guided FNAC or needle washout for PTH, or you can get an FNAC for histopathology. But remember, if there is any suspicion of parathyroid carcinoma, this is an absolute no-no. It may lead to very troublesome sealing. Technetium 99M sestamine planar scan was first described, and as rightly pointed out in the audience, we have now moved to sestamine SPECT scans. This further led to the introduction of PET-CT scans, and we've been using a lot of them. The predominant, however, is 18F fluorocholine. There is also 11C choline, which has quicker acquisition time but has problems, and I'll come to that when we speak about it. A further progression is a 4D CT scan. What is a 4-dimension? I'll let you know. And finally, an age-old technique, invasive, but is used when nothing else is working, that is parathyroid venous sampling. So the best approach would depend upon the patient factors. Is it a redo surgery? What is the risk of radiation exposure and local experience? Quickly, I'm going to briefly go through all of them. I'll rush through these slides. USG is often used as the initial investigation. Simple, it's inexpensive, widely available, non-invasive. It is excellent for detecting large parathyroids near the gland or even close to the upper portion of thymus. However, it cannot detect, obviously, glands which are behind the trachea or the esophagus or those in the ectopic locations. Sensitivity varies with a full sensitivity of around 55 to 87%. However, once it is detected, it has a good predictive, a positive predictive value and a good specificity. The next investigation is a system AV scan, and as I said, it began with planar scans. This is an example of a planar scan. So the principle is that system AV is a lipophilic cation which accumulates in the mitochondria, and this leverages the principle that in an active parathyroid gland, in an adenoma, there are higher proportion of mitochondria, so that it goes and concentrates there. There is a differential release of the tracer from the thyroid on one hand and from the parathyroid, normal parathyroid, and the adenoma on the other hand. This allows for distinguishing of abnormal parathyroids. There are two terms we use here: dual phase and dual tracer. Dual phase just means early and delayed scans. Dual tracer is when you use another tracer to negate the thyroid which you had seen, and then you do a subtraction. So just remember that these are two terms which can be used and two techniques which can be employed. So overall sensitivity is higher than ultrasonography, as one would expect, but slightly lower in small adenomas, and the number there is less than 500 milligram. So SPECT and SPECT-CT is an enhanced BB imaging. It provides a three-dimensional anatomical localization of the abnormal gland. So it provides a much better roadmap. Dual tracer methods can be used so that the interference of thyroid can be subtracted. Once again, the sensitivity goes up as we go further down the list of investigations. The next is PET-CT, and 18-fluorochlorine is one of the best alternatives right now to technetium SPECT-CT scan. Many consider this as the one-stop shop for pre-localization. The mechanism is not exactly clear, but it's probably like the choline enters the cell membrane. Here it undergoes phosphorylation, and the phosphatidylcholine then incorporates into the cell membrane, which is then picked up. So this is the principle. And once again, as you go further through this list of investigations, the sensitivity increases, so does the specificity and the positive predictive value. If this fails, there is a second line imaging, which is C11 choline PET-CT. The advantage is that it has a shorter acquisition time, it has much more selectivity, but it requires an on-site cyclotron, so that really limits its availability. This is just a diagram showing how system AV on one hand and fluorocholine on the other hand act. So as I said, system AV has affinity for mitochondria. It gets concentrated there. There are more mitochondria in an adenoma, so you'll find it there. 18F choline on the other hand enters the cell, gets phosphatized and becomes phosphatidylcholine and becomes a part of the cell membrane, which once again is more in the adenoma. So that is how it's done. The next localization investigation in line is a 4D CT. Now, what does a fourth dimension mean? A fourth dimension is nothing but time. So this uses the temporal perfusion characteristics of the parathyroid adenomas. The parathyroid adenomas typically have a rapid uptake and rapid washout of contrast. So if this is temporally plotted and pictured, then you would get a time dimension to that, and therefore you get a very highly detailed multiplanar images which will pick up the abnormal gland. Once again, the sensitivity and specificity is furthermore slightly more also as compared to 18-fluorocholine PET. It is mainly useful in reoperative surgery, where there's a lot of tissue architecture disturbance, and this will really pick up with a reasonable amount of sensitivity. The only thing is that though the radiation as compared to a SPECT-CT is not much, the entire body radiation, but thyroid specific radiation goes high. So if you're doing it for a young patient, preferably not the first investigation of choice, because the thyroid specific radiation is very high in a 4D CT. The last in line is parathyroid venous sampling. It's not a newer addition to an investigation. It has always been there, but a very invasive investigation. It typically requires the cannulation of the femoral veins, and then you go more cranially and obtain blood samples from more and more cranial veins. So all the way superior vena cava, bilateral brachiocephalic, IJV, and then the superior, middle, and inferior thyroid veins. But this is one of, when everything else fails in localization, this can be used. This has a special value in recurrent primary hyperparathyroidism, where its sensitivity of 75%, absolutely beats the 30% sensitivity of a technetium 99 stent. So we now move on quickly to intraop localization. Localization at surgery is equally important. Whether IOPTH, intraoperative PTH, can be considered intraoperative localization? No. It is a measure of completion of surgery. So there are completely different sets of investigations which we use for intraop localization. One of the basic which you can use is, if system EP has been given, you can use a gamma probe to monitor radioactivity. But once again, this will involve an additional gamma probe. It will require you to do this immediately after the BP scan, and so on and so forth. There are newer modalities which have come forward, which are near-infrared fluorescence and near-infrared autofluorescence. So near-infrared autofluorescence is based upon the self-fluorescing characteristics of a parathyroid. This is called NIRAF, and some of the available products are PTI, Fluoptics, and the Indian iRelic. On the other hand, near-infrared fluorescence uses fluorescence in the parathyroid based with the use of indocyanine cream. Both of these have shown excellent sensitivity and specificity in the backdrop of thyroid surgeries. So most of the data regarding intraop localization using NIRAF comes from thyroid surgeries. There is only emerging data in parathyroid localization. So just to go through that, as I said, there are two methods to detect NIRAF. One is a PTI system, which is a probe-based approach. Now, this is a fiber optic probe, which basically uses the Raman spectroscopy to assess not the autofluorescence, but it is the near-infrared spectroscopy. And this is the output is numerical rather than a visual output, which you will see in an autofluorescence. So this is a probe-based approach, and you have to use that probe over the tissue, and it gives numbers on the screen, which you can then decipher to understand if the parathyroid is there. Yeah, once again, it is not an autofluorescence based; it is a spectroscopy based approach. The real autofluorescence based approach are image based approach, and the examples of which are flow beam, iRelic, and so on. This is a video of the setup of a flow beam. The probe is to be used at a distance of 10 centimeters, so this is a non-contact probe. You'll have to switch off the lights when you're using this, and whenever you're seeing a suspected parathyroid, once again, this is from thyroid surgery, and in fact, until yesterday, I was preparing this talk for identification of parathyroids and thyroid. Only this morning I've changed it a bit. So this is how you will see autofluorescence using, this is an iRelic system. So these are the locations of the superior and the inferior parathyroids. Another case, you can see the two parathyroids there, and as seen on the iRelic system. So these are the pros and cons of the image-based versus the probe-based. The image-based, as I said, is flow optics. The probe-based is PTI. We first speak about image-based. The advantage is that it's a visual impression. It's a global view, and therefore it gives identification before you've done significant dissection. You don't need to put the probe there. It's reusable, and it can be very good for ectopic glands as well, because you don't need to have your probe in contact with that. The disadvantage is, unlike the spectroscopy, there is no quantification, right? It is difficult to do with smaller incisions, and the OT light need to be turned off. On the other hand, for probe-based, it quantifies the signal, so you have a quantification of your diagnosis. OT lights can remain on. It can be done with smaller incisions as well. It gives you an auditory feedback, much like you'll get in an IONM. The cons are the pros of the other one, that it requires significant dissection to be done. There is no spatial orientation. You do not get a visual impression. And both of these will not provide an information on viability. You only get the gland is present, especially the probe based, you will not get the information on the viability. Right, so these are some of the drawbacks or limitations of NIRAF. False positives may occur because of fat, colloid nodule or lymph nodes. You can also get whiteout due to malignancy or intraglandular bleeding or other such metabolic factors. Limited depth penetration, that is a main thing, and no information on the viability of the gland. Which brings us to the last intraoperative localization, which is just usage of indocyanine green perfusion study. And this binds to the plasma proteins and generates fluorescence, which can be seen in the near infrared light. So this is not autofluorescence, this is near infrared fluorescence. So we saw three technologies: near infrared spectroscopy, which is PTI; near infrared autofluorescence, which is flow optics or iReling; and near infrared fluorescence, which is indocyanine green based. So this is typically how it's done. It's injected, and about 1 to 2 minutes later, fluorescence can be detected in the field. This is a video from Dr. Shankara, where he's used indocyanine green with iReling for a parathyroid surgery. You can see within a few seconds, the gland lights up, but the parathyroids light up more, and they can be picked up. So this differential in fluorescence will enable you to pick up the parathyroids. So as I said, this has got excellent evidence for parathyroid detection during thyroid surgery, and there are now at least 3 meta-analyses which will support the use of this as an ancillary investigation for identification of parathyroid in thyroid surgery. But if you come to hyperparathyroidism, the evidence is emerging. Because they're usually more likely to be heterogeneous with NIRAF. The sign typically which you see here is a cap sign, which differentiates the more active part of the adenoma versus the rest of the adenoma. But as I said, the evidence is emerging, and this is not a first-line investigation for this. With that, we'll quickly go through the summary of the localization modalities, and then maybe see a case scenario, and then go through algorithm-based approach. So quickly. What I said, maybe someone can get a picture, but the advantages and disadvantages of this, as we go down the line, they become more expensive, less available, more radiation exposure, and probably, as you go down, more invasive. But on the other hand, on the flip side, there's sensitivity, positive predictive value, specificity, ability to pick up ectopics, ability to pick up multi-gland disease, and ability to pick up a parathyroid and redo surgery, all of that increase. So these are the, that's a summary of all the localization modalities which you can use. Coming back once again to what I was asked to speak, field localization. So what are the scenarios of field localization? Ectopic parathyroids is the commonest, and one must have a very good map of where the ectopic might have migrated, depending upon the embryological tract of migration of parathyroid 3 and parathyroid 4. Another obvious field localization scenario is previous surgery where tissue distortion has occurred. Very small adenomas and PTH not too high, as can be expected, are some other scenarios where localization might not be very good. In the next few slides, we are going to see a few algorithms of how we can approach. So this is from the Korean group. So for candidates for surgery for primary hyperparathyroidism, remember my first slide, proceedings from the 5th meeting, you need to do localization studies. And the first localization studies, the first 2 you would do would be ultrasonography and a system EB with SPECT, SPECT-CT usually preferred. There can be 3 scenarios. Both are positive, both are negative, one is positive, one is negative. So let's go through one by one. If both are positive, then obviously you've localized the gland and you go ahead with the focus surgery. If one of them is definitely positive, you can still go ahead with the focus surgery because you have probably identified the offending gland. If only one is available and if it is equivocal or negative, then you move on to the next investigation in the line, and it would be a good idea at that point to bring in 4D CT, especially if your patient is old and has a recurrent disease. you can certainly go in with a with a full DCT or also a secondary hyperparathyroidism. The third scenario is if both of these are negative or have discordant results. You can do other radionuclide imaging such as choline PET CT, which if positive, you identify the offending gland, go ahead with focus surgery. But if this is negative, then you are brought up to the last scenario, which is venous sampling for parathyroids. It's a cumbersome, invasive technique, but occasionally needs to be done. How frequently, I don't know. Maybe we can have the experts speak to us about that. If this is positive, you've probably identified the offending gland, go ahead with focus surgery. If this is negative, unfortunately, you'll have to do a bilateral neck exploration, 4 gland exploration. So that is from the Korean group. Dr. Karthik was kind enough to actually send me this morning while I was sitting here in the audience, and this is from the UCSF. The UCSF guidelines, they've divided this for first-time surgery and redo surgery. So the algorithm that we're seeing now is for first-time surgery. You have a candidate for surgery. Once again, you do an ultrasound and a DV, preferably with SPECT. If both are positive and concordant, go ahead with the focus surgery. If one is positive or one is negative, this guideline is slightly different from the earlier guideline. In the earlier guideline, you would have moved on to the next line of investigation. Here, they advise to go ahead with the focused exploration and do an intraop PTH. If your intraoperative PTH documents are less than more than 50% drop, then you've removed the offending parathyroid and can come out. If it doesn't, then you have to do a unilateral exploration, like 2 gland exploration on the same side. So this is where it's slightly different from the previous guideline that I showed. If both of these are discordant or if both of these are negative, then unfortunately you'll have to go with a bilateral 4 gland exploration, obviously with intraoperative PTH control. So this is for primary disease. How about for redo disease? In a redo disease, the goal is that we need at least 2 concordant studies. So once again, you begin with ultrasonography and a SPECT maybe. If both are positive, great, you've identified the offending gland, go ahead. If only ultrasound is positive, then you either go on to the next study, or you can consider FNA with PTH washout or cytopathology, both. In case you have to go on to the next study, it can either be an MRI or it can be a full DCT. If you get concordance of both of these studies, then you go ahead with your focus exploration and have an intraoperative PTH control. If once again you do not have concordance, then you move on to the next study, which is venous sampling. If you get concordance with this, once again you go ahead with focus exploration and intraoperative PTH control. If once again there is no concordance, then you unfortunately have to do observation and follow-up. And I'm ending this talk with one study. This is not mine. One case. I'm sorry. This is a hypothetical case I made up based upon some representative images I got in a journal article. So let's say this is a 60-year-old female. She has got renal hyperparathyroidism. She received a renal implant which has failed. Her PTH is rising. USU was done, which was failed. Technetium 99 SPECT CT was done, which showed on one side there is a hyperfunctioning gland. On the other side, there is an equivocal focus, large focus, which is of thyroid. My question is, should a 4D CT be done now, or how would you proceed? This section, someone is supposed to ask me questions, but maybe I can put it to the front row here. Or would you go ahead with the 4 gland exploration?
So renal HPT,
all 4 glands are usually involved, so a bilateral exploration.
A bilateral exploration. Because of,
in fact, you should not do any localization studies in renal HPT. It sort of misguides you.
but
Because one gland will take up maybe, and you would think that one gland is, but renal HPT affects all 4 glands.
But is it of value at least to identify the most offending gland?
No. If only tertiary hyperparathyroidism, you can go for a focus. But for a renal HPT, secondary hyperpara, the rule is to go for bilateral exploration. Because you have to do a 3.5 gland,
You have to do a 3.5.
at least a near total parathyroidectomy.
So is it of value to identify the most offending gland? So
not at all. In fact, it misguides you.
Okay, yeah, right, and I think that brings me to the end of my initial intro or primer on localization, and we can now move on to the next studies. Thank you very much, and do remember the single on rhino when you think about parathyroid disease. Thank you.
Sir, amazing talk. I have one small question. So So the autofluorescence which you have used, so what is the difference between using ICG and without ICG? So does it even autofluoresces the parathyroid gland? After removing from the body, does it still autofluoresce, and what's the difference between without using ICG and with ICG?
So for autofluorescence, it shows that there is no indication of viability. And autofluorescence, as Professor T. Cruz pointed out yesterday, it will probably autofluoresce in the sample bottle as well. So that's certainly what happens there.
Yeah. So in the parathyroid adenomas, they don't light up autofluorescence.
Yeah.
So yes, in fact, 2 days back I did a case where you will find the adenoma is black, and as you rightly mentioned, you get a very nice cap sign.
Yeah.
So the normal parathyroid tissue will fluoresce, and that corresponds very nicely with your histopath picture. If you ask a pathologist to give you a scanner view, she would show, or he would show, that there is a parathyroid adenoma, and at the periphery you have a normal parathyroid tissue which actually autofluoresces and gives you the cap sign.
So the more fluorescing is the normal part.
It's a normal part.
And
So
if,
I agree
and therefore,
totally.
corollarily, if the entire gland is involved, it will not fluoresce at all.
Yeah, so usually the diagnosis of adenoma is made by pathologists based on the compressed normal parathyroid tissue at the periphery.
Okay.
And that is what autofluoresces. If you don't get a normal parathyroid tissue, the pathologist will never tell you that's an adenoma or hyperplasia. It is that particular thing that actually differentiates from hyperplasia vis-a-vis adenoma.
So intraop localization using
Autofluorescence of no value.
is of no value
No
for
value.
parathyroid surgery.
Yeah.
All the
But
studies-
it does help you if there's a normal parathyroid lying close by. You
Then
would
you can
pick up
avoid
that.
that.
Yes, you can avoid.
So
avoid
it's
that.
a converse rule where you can use it.
Absolutely.
Okay.
So I agree totally. I also use the autofluorescence, the fluo optics for the parathyroid adenoma. So as he rightly said, the normal part only will shine up, and that's where the cap sign is seen. So you really don't have an advantage of using autofluorescence and
Yeah.
even the
So all the
ICG
studies
for
have been predominantly in thyroid surgery.
for
As I
the
said,
adenoma, but you have an advantage if you are looking for the other parathyroid which are there and
Yeah.
you wanted to
correct, which is
do
what sir
something
said.
with those
The
parathyroid which are
advantage is that if
normal.
there is a normal parathyroid nearby, you might avoid
Inadvertently
inadvertent
yes.
resection of that.
So that is the advantage only of autofluorescence, not for the adenoma per se, for the other normal glands to look into the field. So, and it does not actually give you any advantage if you give ICG also to this. You can't even localize it. It just everything shines up. Nothing you can make out in that. Yeah.
So once again, all this is intraoperative. Near infrared is mainly for thyroid surgery, where you want to localize and preserve
Normal
parathyroids. Normal parathyroids. For a parathyroid adenoma, only the cap sign is what you can get, and it's converse. You will probably see a normal parathyroid and avoid it rather than a parathyroid adenoma.
Yes, just to add a point on that. So for identification of parathyroid during thyroid surgery, we have just completed a meta-analysis on use of near-infrared autofluorescence with and without ICG. So there we found out that use of near-infrared autofluorescence does not reduce the incidence of permanent hypocalcemia, but it reduces the rate of temporary hypocalcemia,
Which is of value as well.
which is of value.
Yeah. So this is for thyroid surgery.
For thyroid surgery, not for
Now
parathyroid.
I'm a little bit confused. What is the best?
We'll come to
I'm a
that.
little bit confused. What is the best method now for intraop localization?
Intraop localization for parathyroid is there
Don't
is no
need
good
it.
method. There is no good method.
So the summary
IOPTH,
of the talk would be
IOPTH acts as your control for ensuring that you've done an optimum surgery.
correct. That we anyway do,
Yeah,
but
your pre-op localization should form your a roadmap for exploring intraoperative.
Intraop localization, you need a good parathyroid.
Yeah. So we go back to what you had said. Find a good parathyroid surgeon, and that's the best localization you can do. Yes.
Read your pre-op all the investigations.
So you said you give ICG. Now, if I thought you are giving ICG, how much dose would you give? 1 ml, 2 ml? How much would you give? Because ICG flushes up, brushes up very.
So I'll be very frank. I really guys have been coming and doing that for us. We haven't procured that thing as yet, and the video that I showed from one of the case which we done as a demo case.
So it's a 600 rupee,
Yes,
600 rupee sample. Or two patients in one vial, and that's a powder form, and you put and make it up to 20 ml, and you can inject up to, I think it's 5 milligram per kg body weight kind of thing. But the thing is, timing is very important. The moment you give it, within a minute or two, you have to really look. Otherwise, everything becomes green.
And if there's a lot of oozing and all, then the entire area becomes, so it should be dry.
The other thing is, if there is slightest amount of spillage, it will just light up and it's a light up brighter than.
And safety in children has not been documented, so you would avoid using acid.
So you should use two, three precautions. You have to do it. That patient should not have a allergy to the iodine. So you have to take that history properly.
It goes unsaid for any iodine.
Yeah. So, but that is the must before you use it. You
Theoretically,
cannot
yes.
just use it because you feel like intraop. You have to have a consenting before that, and you should do that. And I use a 10 ml. For the dilution, and you can further dilute it when you withdraw 1 ml to another one. So you get a 2 ml diluted one, and that you can use it. And before that, your camera or whatever is your equipment to guide your knee raft, that you should be kept ready, and the anesthetist gives the drug, and you are ready to capture every movement of the light up what you see it on the images. And then there is a washout. There you actually read the images on your grayscale or whatever scale you are having, and then you will get the light up. So that's how it is done.
In fact, you use autofluorescence to identify
Yes.
and ICG to see the viability.
Yeah.
Unfortunately, with ICG, you cannot identify. You have to visually identify the gland, and then the ICG tells you that this. So, if you use both techniques together, they complement each other.
Yes.
So, with autofluorescence, you can identify, and then with the ICG, you look at the viability.
Because
So
ICG by
nowadays
itself is
people
not
are
great
coming
for
up-
localization. ICG by itself is not great for
Yes.
localization. So you do an AF autofluorescence, ICG is
So it's a
fluorescence.
combination. You have a fantastic equipment. You have to know how to use both with the combination of the dye. And when you see the on the ICG, the vascularity of that tissue, it will go from the gray scale and the white, black. So you will have the vascularity, and that is what it is described. So you need to know
So
the
once
data
again,
is
this
still not
once again,
foolproof
before-
on that.
Before confuse this is on the ICG part.
The ICG
AF
part.
will continue to fluoresce even if it's taken out.
Now,
Yeah.
one question can be asked: if you on the ICG you see the viability is not good, what will you do? What is the purpose of doing ICG? Suppose you see in one gland the viability is not there. So there you can do the knife test. If it is congested, you just stab it with a fine 11 number blade and let it oozing take place. And believe me, the congested gland you will see suddenly it becomes normal. So this is very important. You might have saved a gland which is congested, but it will not function. So unless you stab it, let the blood ooze out, and you'll see the color has changed back to normal. So a black gland immediately becomes a very maroon colored, normal color of the parathyroid. So you have to take action on your ICG thing. That's important.
I think I should thank you all for the clarification. I was almost going to ask my institute to invest and buy this. So now
Please buy it. Yes.
But I don't know if it is so much of a confusion.
No, see, I have been using autofluorescence very recently, and just like neuro monitoring, I think every parathyroid or thyroid surgeon should have autofluorescence. I'll tell you why. The inferior parathyroid glands are very difficult to pick up, because what happens by the time you have mobilized the gland, you have already damaged the inferior parathyroid supply, because they lie very anterior. Now, if you use autofluorescence early on, you will detect that inferior parathyroid gland. They are very small within the fascia and they are very anterior, and you just tease it away from the gland. So autofluorescence is very, very helpful. Similarly, the superior parathyroids are within the, once you take down the pedicle, the two leaves of the fascia, in between there lies the superior parathyroid gland. Very, very difficult to localize. But with autofluorescence, it helps you to preserve the vascular supply very early on.
So it's still worth it.
Definitely it's worth it. The only thing is you have to get used to that technique. It takes time to develop a protocol. Like ICG, at what time you have to see, as Anjula was saying, you have to be ready with your protocol. You have to re-inject again, you know that. Similarly with autofluorescence, when to use it, you develop a protocol, but it's going to be a very, very useful technique. As Karthik was saying, for an occasional thyroid surgeon, if you save one parathyroid gland, the patient will not develop permanent hypocalcemia. That's a surety. And that's why a few years back it was said that you auto-transplant at least one gland so that the patient doesn't land up with permanent. But unfortunately, auto-transplantation doesn't guarantee again a functioning gland. But with the autofluorescence, at least a novice or an occasional thyroid surgeon can preserve one parathyroid gland at least. So it's a very good technique. The only thing is the resolution of the machine, flow optic resolution is very good. I've started using Irelec. Irrelec is good, cheaper, but the resolution is not so good.
Yeah.
Fluoptic was not available in India till now. They recently have had an Indian distributor.
What's the cost?
The cost of Irrelec is 30 lakhs, 35 lakhs, and Fluoptics is believe is 80 lakhs.
80 lakhs it is.
Yeah. So, but Irrelec, start using Irrelec. They will come out with the next generation machine sooner. But I would recommend definitely use autofluorescence, just like neuromonitoring.
Certainly for thyroid surgery.
Yeah, I'm talking about thyroid
Yeah,
surgery,
but
not for parathyroids. For thyroid surgery, having neuromonitoring equipment in your theatre and an autofluorescence is a boon. It really improves your confidence. See, the surgery is all about precision now. Even if you can give 1 or 2% of more precise surgery, it's worth it.
Now, one more question. The auto implantation of parathyroid. Many of the people they embarked on this. Anybody has studied how long it will take to come back to the function, and how they have assessed the
Yeah, so-
leaving the improvement of parathyroid that we have left. Whether patient is improved because of leftover parathyroid or implanted parathyroids.
Yeah,
Nobody has
Typically, it is
assessed.
wrong to take all 4 out and then auto transplant. So nobody has done that kind of a head-to-head comparison, But still, it takes 1 to 3 months for the auto transplanted gland to function, And if you've really maintained, for example, you've auto transplanted sternum-mastoid and there's a lot of oozing and bleeding, that will compromise the vitality of implanted parathyroid tissue. So there's a lot of tips and tricks for the technique of auto transplantation as well. Although it takes 2 or 3 minutes, but it requires a bit of learning curve to have a good auto transplant result.
So
Do you do it in
just
the
one-
forearm or in the sternum?
Sternum-mastoid easy. You already opened up the neck. There's no. Long time back, it was recommended brachyradialis and all those things, especially for the secondary hyperparathyroidism. But for primary hyperparathyroidism, you have the leg exposed. You just take an artery forceps, make a space in the sternum-mastoid, and put the parathyroid tissue. But make sure there is no bleeding and no.
Sometimes we put a small.
You can put a clip or a suture.
Yeah.
So my experience about the auto transplantation of the parathyroid gland in MEN1 and the MEN2A, which are high risk for the hyperparathyroidism, you don't want to go in the field. These are the only indication to so I have done it in 2 patients. So that's it. My experience about doing it. And the second thing about the auto transplantation is how much time it takes. So it is said that you have to reduce the surface area. So you mince it basically about a millimeter diameter. So the parathyroid can get the blood supply directly from the bed. And the data says it takes 3 months to 6 months to adopt and start functioning. So you actually get a temporary hypoparathyroidism if you remove it more than 2 glands. But you actually, when it starts functioning, you will not have a permanent hypoparathyroidism. The requirement for the calcium will reduce. But if you are done, already you have one functioning parathyroid with the vascular pedicle, the patient may not manifest also, and you really don't know auto transplantation is working or the original surgery, the good surgery is working for the patient. So that is always a dilemma, and because there are 4 parathyroids and one will somewhere it will be functioning. So God is great. So maybe we are not relying totally on the auto transplantation.
I think the philosophy is unless you've damaged one, you do not auto transplant.
Yeah.
One other interesting advantage of autofluorescence is this: if you have inadvertently removed the parathyroid on this specimen, you do an autofluorescence of this specimen, and very nicely you will see something is autofluorescing, and that is your parathyroid which is in it, and then you can auto transplant it. So again, it helps the surgeon to auto transplant inadvertently removed parathyroid. So that's an interesting take on autofluorescence. I've done in one patient, and we could see there's something is shining on this specimen. We removed it, sent it for frozen, and they said it's a parathyroid, and we auto transplant.
One more thing, what I have noticed that I was doing a redo thyroid case, and the previous surgeon has auto transplanted into the sternocleidomastoid, but I was unaware about it, and he had a deposit of the PAP-CA everywhere and all that, and I felt there is some nodularity in the sternocleidomastoid. I said, I was wondering, it's in the skin also, small nodule was there. I said, this is in the sternocleidomastoid, and to my surprise, when I excised and sent it, it came as it was a parathyroid. It was like it's fibrotic, and it is like as if like it's a deposit. So it is always a good point that you mention and take a Prolene stitch. It's like a non-absorbable stitch or some Because if you are using clips everywhere, you will not recognize at the end of it. So you put a Prolene stitch and you mention in the notes that where is the location approx, like lower 1/3 or anything, and the Prolene stitch, so that if you need to go back, you know exactly, and you don't inadvertently remove that kind of a site. Yeah.
Do a service for the next surgeon at least.
It's a 4-0 Prolene. It doesn't cause any problem to the patient. You take it so many times for the great
For
vessels.
benign cases, if you're auto-transplanting, it doesn't really matter. You use an on. But
Yeah.
for MEN cases, obviously, you would prefer doing in brachyradialysis than sternocystectomy.
Yeah.
Right. Just to add one more point, recently I had a word with Dr. Frederick Triponis when we were discussing about the NERAF manuscript. So they are actually coming up with a computer vision algorithm, so which will be able to identify the intensity between the thyroid gland and parathyroid, and also they are planning to make it the cutoff intensity for viability with ICG injection. They are standardizing the dose. So actually we are working with IRLIC to develop such model here. So again, just a small thought on that. So I had a question for you, but I'll ask you during this thing with respect to the remote access. So I'll ask you during.
I'll show you the video, sir.
Right. I understood. So I'll
and
ask.
also you were talking about the algorithm.
Right. So that
Actually,
is
we are also working on
that
with the VIT.
VIT.
So,
And
we
so
are
actually
doing
that was initially started by the University of Brassica group, I guess. So they have the algorithm where they're able to point out the parathyroid during the remote access.
Yeah.
Right.
And there is one definite advantage in remote access. You are, especially in rabbit, what I do, or any endoscopic, where you are using carbon dioxide. The advantage is that your field is dark. You are fully in control of your vision. So that makes a huge difference in the ability to identify. But the negative side is there is no autofluorescence. So, but can we overcome that using indocyanine green? That's where the thing comes. So see, I have done now more than 100, nearly 200 minimal access thyroidectomies. So I think over time I have developed some tricks to come over the deficiencies. So I think that's what I'll try to share it as I do.
Yeah, you have the flywheel technology for the ICG.
Firefly, yeah.